The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. It is another Tuesday. The date is July 30th, 2024, and we are gathered here for the next episode of TMD Demystified. I am Tony Urbanic. Today's title that I've chosen for the presentation and information is TMD, TMJ, Separating Fact from Fiction. Now, this is actually the broader topic that I've been discussing on several episodes over the past 3 years. It has been generated around the fact that I have discovered, and I'll use the word generally, because what I discovered has already been in the literature and known by many other doctors and scientists and researchers as it applies to the cause of temporomandibular joint disease disorder. And that is, inflammation drives each and every one of the TMD symptoms. We've discussed that many times before, but the point then is once that is understood, utilized in the diagnosis and treatment, it naturally uncovers all of the ineffective kinds of treatments and inappropriate types of diagnostic tools and services and methods used for the diagnosis of, quote, TMD, TMJ. And for the benefit of those who listen, and hopefully some of you will go on to accurately, appropriately treat this problem with its numerous disparate symptoms, you will come across in part of your diagnosis and treatment, dealing with patients and dealing with other doctors on this issue. They will bring up from time to time, hopefully over a period of time, less often, issues having to do with what has been done for this problem diagnostically and treatment-wise for the past 70 years, which has been inappropriate, ineffective. It is my duty, knowing the facts about this, to bring to your attention the actual facts and dispute, and I'm willing to dispute in a rational way each and every one of the things, services, ideas, concepts that have been out there for 70 years that really is ineffective and a waste of time and effort and money, which has led to the fact that, and this is indisputable, that this is the consensus opinion of everyone but a few TMD gurus out there, that when it comes to TMD, nothing works. That's the consensus among physicians, among dentists, among the dental establishment, among dental schools. The consensus is that when it comes to treating TMD, quote, TMJ, nothing is effective, nothing works, which is a shame, because we as a profession have been led down the wrong path. It hasn't been a rosy path. I can't say it's a rosy path. We've been led down the wrong path. So in an attempt to correct this problem, which was self-generated, I do these episodes on this podcast, in one way or another, bring to your attention the facts and the truth. In this episode, which is entitled TMD TMJ Separating the Fact from Fiction, I am simply going to compare the fact that inflammation, chronic inflammation within the temporomandibular joint via the autonomic nervous system stimulating muscles to tighten up and create trismus and muscle pain by pulling on the bone, or chronic inflammation within the temporomandibular joint seeping into the middle ear via the petrotympanic, quote, glossarian fissure into the middle ear, creating tinnitus, subjective hearing loss, and vertigo. And the fact that chronic inflammation within the joint causes the synovial fluid to become sticky like glue and lose its lubricating value, leading to and stimulating various kinds of jaw locking. Those are the facts. And in my mind, and according to the study that proves the effectiveness of unloading a joint, decreasing the inflammation adequately, will successfully alleviate 90% or more of the symptoms, leading to a success rate based on patients' approval of the method of 85%. 85% success defined as patients' approval and appropriate treatment in their mind. And a little higher when it comes to decreasing each and every one of those symptoms. All right, so what I'm going to do is I'm going to take on each and every one of these prior, first of all, diagnostic methods or tools, and discuss them as it is appropriate to compare and contrast it with inflammation within the temporomandibular joint, to show how that diagnostic tool or treatment or actual treatment of the symptoms themselves are ineffective, inappropriate. And so let's just go over these. And this is practical knowledge. This is knowledge, again, hopefully you get the point. It's not to make my colleagues wrong. It's not to create a conflict of paper emails going back and forth, although I accept any kind of communication, trying to dispute or dissuade the fact, which already is in the literature, that inflammation, chronic inflammation in the joint causes muscles to tighten up. That's why tennis elbow and TMD are the same disease. So let's start out, number one, with the diagnostic tools that have been used, and with money wasted and time wasted and effort wasted on the treatment or diagnosis of TMD. So let's start out with the cone beam CT scan. We all know what a great tool it is. No dispute on certain types of patients that the new technology, or newer technology now, of cone beam CT scans are irreplaceable when it comes to diagnosing positions of implants or doing orthognathic surgery, treatment planning for an orthognathic case, or diagnosing the extent of tumors or cysts within the oral and maxillofacial region. Just, it's irreplaceable technology. But is it necessary and appropriate to take the X-ray, spend the radiation and the money associated with it as a necessity for diagnosing TMD? Well, a plain film, a Panorex, is more than adequate, because it is irrelevant how much damage is done within the temporomandibular joint, because it's all about inflammation. A cone beam CT, although it can detect swelling, but it cannot detect chronic inflammation per se. It can, a CT and a plain film or Panorex can certainly depict the amount of bony degeneration, although neither cone beam CT or plain film Panorex can detect changes in the cartilage. But the point being that a cone beam CT is definitely overkill for looking at a temporomandibular joint. The primary reason for a Panorex is to make sure that the healthcare provider is not missing some glaring type of problem that might be confused with TMD, which could be a cyst, a tumor, foreign body, all the things that you'd be looking for on a Panorex, associated with actually damaged teeth, things like that can be picked up nicely on a Panorex. A cone beam gives you more information, but when it comes down to the necessity of a cone beam to diagnose anything that is necessary to see, whether or not the joint has significant changes or not, is not necessary. Now, you may get one. You may find that you or your patient wants to spend the extra time or money, but I can tell you it is not necessary. A simple panoramic film is more than adequate to rule out any major kinds of conflicts or symptoms or signs of other problems that might need to be addressed that could confuse TMD with something else. Another example would be a sinus is full of junk, which can easily be seen on a Panorex. So you don't need a cone beam CT to diagnose TMD. The next is an MRI. And of course, in my earlier career, for the first 36 years of my career, I must have ordered a couple thousand, probably more, because I did 2,000 MRI, 2,000 TMD surgeries. So if that be the case, then I probably ordered in my career 4,000 MRIs specifically looking at the temporomandibular joint for the position of the temporomandibular joint disc, whether it was dislocated, not dislocated, whether you could see any damage. Now, an MRI at this point in time can only be done in hospital settings or large clinical settings, although I understand that there are MRIs that are now soon to come out that can be used in an office clinical setting, which will be an interesting thing to watch. But that's a whole other topic. But can an MRI add anything significant to the diagnosis of temporomandibular joint disease, as opposed to the understanding that it's all about inflammation and it does not make any difference where the disc is, where the disc is. The disc can be displaced. You can have significant damage to the bony features of the temporomandibular joint, but what you're really looking for is chronic inflammation. So an MRI, again, is very, very much overkill, because I have shown many, many cases of terribly damaged temporomandibular joints, which in my earlier career would have definitely been a surgical case, while unloading the joint with a posterior disoccluding device, anterior occlusal posterior disoccluding device, will take the load off the joint and remove all the symptoms, much better than any surgery that I ever did. So again, the MRI, a couple $1,000s a whack, maybe a little more, will certainly show you the precise position of the meniscus and how damaged it is and what degree of bony damage goes on within the joint. But will it add anything significant that would change the diagnosis or change the treatment plan of disoccluding the posterior teeth to relieve all the symptoms? Would an MRI be necessary? And the answer is absolutely no, not necessary. So you're wasting time and money. And in the end of it all, you may say, well, it's the insurance company's money or it's the employer's money, or No, in the end, it all comes down to all of us. We all share in the cost of our insurance coverages and our premiums, et cetera. One of the foolish ones, I must say, it isn't foolish to get a CBCT or an MRI, although it's not necessary. But I know of and continue to hear TMD gurus who make a big deal out of auscultating the temporomandibular joint with a stethoscope, listening to joint noises, trying to make some kind of definitive diagnosis or variation or classification on noises, which is actually kind of silly. Because it makes no difference what kind of noise is coming from the joint, and auscultating the joint doesn't prove anything. It is not diagnostic in any way, shape, or form, other than to say that the joint must be damaged. If it's making those kinds of noises, it's damaged. Whether you hear it through the stethoscope or you can hear it through the door, which can occur in both cases. I've heard joints make as much noise you could hear them across the room. Auscultating a temporomandibular joint proves nothing, so it's a waste of time. And the last one I want to just speak of briefly, and there are others that I could speak of, but the electromyography, EMG, which to this day is used by some of the TMJ, quote, specialists to document the normal function of muscles or the abnormal function of muscles having to do with the muscles of mastication or the muscles of the neck or the muscles of the shoulder or upper shoulder girdle, which again only proves if you get the variations on an electromyographic readout that the muscle is tight or not tight. And that's all that you can prove, but does it have any diagnostic value at all? No, what it's telling you is the muscle is tight, and if the muscle is tight, sooner or later, it is going to pull on the origin insertion on the associated bones and periosteum, which will stimulate pain by stimulating the nociceptors in the periosteum. But does it have diagnostic value to hook up a machine to your muscles and to say the muscles are tight? Is that diagnostic? No, it is not diagnostic because it's so simple to make the diagnosis of TMD, which is nothing more, nothing less than collecting symptoms, saying that if you have a number of symptoms, those are red flags. You can't diagnose off of symptoms, and a positive electromyogram would, certainly certify that the muscle is tight, or you could feel it, or the patient could tell you that that muscle hurts, all of them being pretty much of equal value. But the point is, it doesn't add anything to the diagnostic value of the situation. The diagnostic method, which is so simple, is to collect symptoms. If you have a number of symptoms, those are red flags, which would indicate that you need to put TMD on your differential diagnosis, and then do this little maneuver on the temporomandibular joint, open and close, with pressure on the glenoid fossa as you close rapidly, and if it hurts, the joint's inflamed. By definition, if it hurts, the joint is inflamed. And inflammation of the temporomandibular joint is the diagnosis of TMD. Let me repeat that. Inflammation of the temporomandibular joint makes the diagnosis. That is the diagnosis. Frankly, TMD should be defined. The appropriate definition of TMD should be chronic inflammation within the temporomandibular joint. That is TMD. And you treat it appropriately by decreasing the inflammation, not by decreasing symptoms. Now, you can go ahead and decrease symptoms all you want. We'll talk about that next. But if you decrease the cause, the common denominator, the keystone, then you don't have to worry about the symptoms. The symptoms diminish naturally. just by decreasing inflammation within the temporomandibular joint. I've spoken on this so many times, but I'm putting this together on this episode to kind of draw together, again, the facts versus the fiction and the fictitious concepts that are out there that are driving patients up the pole, running them around in circles, because just treating symptoms is only temporary. If you're just treating a symptom, sooner or later, that treatment for the symptom is not effective or has to be repeated multiple times. And we will talk about that as we go down the next list, which is the list for treatment rather than diagnosis. So the next item on the treatment list, and these are by no means in level of importance. I just made the list and we're going to go down them as they came to my mind. And I'm sure I missed some. I'm sure I'm overlooking some, but I'm just trying to make this point for your education. So primarily, as you talk to patients and you talk to other practitioners, whether they be practitioners who already are treating TMD in one way or another by their own methods, or by their healthcare providers who want more information, or healthcare providers who just, have heard about doing what one thing or another and would like your feedback on it, what you think about it, which is the most common. What do you think about fill in the blank? We hear it all the time in this office with patients, and you fill in the blank on anything. Doc, what do you think about blah de blah, when they've heard on Dr. Google or they heard from the next door neighbor about TMJ and somebody treating TMJ with fill in the blank. So we're going to fill in the blank with probably about, I don't know, it looks like about a dozen specific items that I'd like to discuss, and discuss them from the viewpoint of fact versus fiction. Fact versus fiction. So the first one on the list here is on the subset of treatment modalities is dry needling. Now, I've never done dry needling. I know it's primarily used by physical therapists. It is not without complications. I have had a patient who had a pneumothorax created by dry needling. Literally, the needle stuck directly into the top of the lung, creating a pneumothorax, ending up in the emergency room and in the hospital with a chest tube. So dry needling is not a simple, it sounds like a simple procedure, but it can have some catastrophic side effects. The point being, the theory, and no one can say for sure, is to my knowledge, I do not read the science on dry needling, but what I understand and what I have read is that the theory behind it is a dry needle into a muscle will create the circumstances where it will relax the muscle. How many needles need to go into a particular muscle? I have no idea. Do the physical therapists use this as a procedure all the time? Are they now trying to apply it to muscles of mastication and muscles of the neck for temporomandibular joint disease? Yes, they are. Is that necessary? No. Is it temporary? Yes. How long will dry needling allow a muscle to relax and quit putting traction on the periosteum of adjacent origin insertions of the bone? I don't know. I imagine it varies from patient to patient, and the practitioner, the technician, how they use the needle, how many needles they put in, I would assume, but certainly it is only temporary. Whereas if you unload the temporomandibular joint with a device that continues to keep the temporomandibular joint unloaded, allowing the inflammation within the joint to go down, according to a proper protocol, the efficacious nature of that is continuous. Continuous, then you could define then as permanent. If it's continuous, then it would be a permanent diminishment of the symptoms themselves, which is what we're looking for. So it's permanent versus temporary. Next one is Botox. I've talked so many times about Botox. I just recently did an episode on Botox being equivalent to injecting saline, based on an extremely well put together scientific article in the Journal of Oral and Maxillofacial Surgery, scientifically, statistically proving that you can inject Botox or saline into the masseter or temporalis muscle for the treatment of headaches and jaw pain because the muscles are tight. The muscles will relax, certainly with Botox because it paralyzes them, but also saline. So the fact that they claim Botox is the solution for TMD, no, it is not. It is equivalent to saline in its use, certainly in the study that was done on temporal muscles and masseter muscles, and it's certainly only temporary. So is it appropriate to use Botox for the treatment of TMD when you're only treating symptom? You're only treating one portion of the symptoms, maybe even only one muscle, and it needs to be repeated multiple times if you're going to use it versus something that is consistent and, quote, permanent over a period of time as long as you apply the proper protocol. So Botox is a waste of time, extremely expensive, and can go on for years. I've quoted many times the patient who swore to me, and she said she'd bring in the receipts if I wanted to see him, $200,000 worth of Botox over a period of 10 years. That's $20,000 per year paid by her and her insurance company. Next is acupuncture. I know very little about acupuncture. I think acupuncturists themselves don't have a really good idea how acupuncture is effective. I think it has some effectiveness in relieving pain and relieving trismus in muscles. Again, it may be just the needle into the muscle or into the upper layers of the epidermis that creates the relief. I don't know, but we do know it needs to be repeated multiple times, and I won't go deeper into that and how deeper than that and how acupuncture may be effective. But again, you're only treating symptoms. You're not treating the cause being chronic inflammation within the temporomandibular joint. Next up is relaxation techniques, relaxation exercises of the muscles. Again, it's only temporary, in this case, very temporary. I think you can include on and off heat because I recommend for my patients, or, as a temporary relief of symptoms until we can get the patient into a disoccluding device to use, soft food, non-steroidals, which they've already done almost always well beyond the non-steroidal point of relief, and then on and off heat. But that would, on and off heat and relaxation techniques would do relax muscles. Is it temporary? Yes. You get long-term relief? No. And is it really an appropriate treatment for any TMD symptoms other than very temporary relief in preparation for a longer-term treatment? That's all it's good for. Same thing with exercises. But the last thing you need to do and want to do is exercise the jaws, and I hear that often, mainly from the dental community. I don't know where they get this from, but it is on the internet. I've seen that in multiple places, different exercises of your jaw for temporomandibular joint problems. Well, that's the last thing you want to do. You want to rest the joint. If you have tennis elbow, the treatment is to put the arm in a sling and rest the joint. If you have a bad hip or a bad knee and you're not going to have surgery anytime soon for one reason or another, you use crutches to unload those joints to allow the inflammation to decrease. So exercises is actually the wrong direction to go when it comes to relieving inflammation. All exercise does is stirs it up. And I tell patients all the time, opening wide at the dentist to get the upper second molar root canal done, or yelling at the dog, singing in church, you open widely and you stretch the temporomandibular joint. It's going to stir up that chronic inflammation and make it worse, not better. So is exercises appropriate? No, that's very much inappropriate. Biofeedback, again, what's the theory there? If you have less stress, more relaxation will not stimulate the muscles. True. I think that's a very true statement. But is it temporary? Yes. Does it need to be repeated constantly? Yes. Is it comparable to just getting rid of the inflammation within the temporomandibular joint by constantly unloading the joint over a period of time? It doesn't even compare. You're just treating a symptom rather than the cause. Night guards, I've discussed that so many times. The night guard does a great job of covering the surfaces of the teeth, protecting the surface of the teeth. So then in the instances of bruxism, you can't damage the teeth, but it doesn't have any effect other than most of the time actually increasing the amount of force that can be placed on the temporomandibular joint, because you're not disoccluding the posterior teeth, you're actually increasing the occlusion of the posterior teeth, biting onto and through a night guard. And that is the treatment of choice by 50% of the dentists in the United States of America. If a patient comes in with TMD symptoms, they will be prescribed a night guard, upper, lower, or both, of various kinds, soft or hard. And again, discussed thoroughly, but is a night guard effective? No. The theory behind it, is it valid? No. Is it trying to treat symptoms? Yes, but certainly not effective. Ultrasonic treatment of the temporomandibular joint. I myself have used ultrasonic treatment on the joint to help decrease inflammation, but it's not effective over the long term. I've used transcutaneous drug therapy called iontophoresis with a very small electrical current and topical medication like lidocaine or steroids, with driving that medication through into the temporomandibular joint. Again, it gives some short-term effectiveness. You do not have to inject the joint, which is a no-no, totally inappropriate to inject the joint with steroids, but driving it through the skin, it has some benefit, but again, only temporary, very, very temporary. Over a long term, you'll just have to repeat it time and time and time again, rather than get rid of the inflammation permanently by unloading the joint. Transcutaneous nerve stimulation same thing, just tends to relax muscles to a degree. It does, very effective on other parts of the body, but very temporary. And then let's go into the last few here very quickly and wrap this up. Chiropractic, again, it is effective temporarily, and chiropractic doctors kind of rely on routinely coming back to their office over a long period of time. We're talking years, to effectively relieve muscle pain, muscle tightness. And of course, the chiropractors have that little gun. I'm not sure what the theory is behind that. I know all about the little gun because I hear about it. It actually puts an immediate pressure on the temporomandibular joint. Maybe that does relieve the temporomandibular joint inflammation a while or stimulate the muscles. I'm really not sure. Does it need to be repeated to get any relief at all? Yes. Is it really effective? Not in the long term. If it's effective in the short term, it's only short term, not long term, and you're not decreasing the inflammation within the joint long term at all. There's a new theory or service on the block, which is low light laser therapy, which I think has some value in treating chronic inflammation in different parts of the body. It has not been researched adequately, I don't believe. I think it's been researched enough that shows that it has some value. Again, it needs to be repeated constantly. So it's rather short-term in its effectiveness. but not as effective as just decreasing the inflammation within the temporomandibular joint. Orthodontics, of course, has been tried and continues to be tried and recommended to get appropriate occlusion. Straight teeth converts, the theory is straight teeth converts into temporomandibular joint relief. No, that does not convert into temporomandibular joint relief. If you have a proper occlusion, it certainly can help in decreasing the loads off the temporomandibular joint. And we have many patients who have functional malocclusions with class 2, class 3, bad class 2, class 3 bites, which need temporomandibular joint, which need orthodontics and orthognathic surgery to help alleviate the undue pressures, loads within the temporomandibular joint. But it doesn't in itself decrease inflammation in the joint consistently and predictably. No, not predictably at all. Reconstruction of the occlusion, same concept as orthodontics. Reconstructing 28 teeth to get a perfect occlusion is a nice idea. Is it predictable as far as relieving inflammation within the temporomandibular joint? No, it is not. It is not predictable, as opposed to just unloading a joint, unloading an elbow, unloading a knee, unloading a hip, or unloading the temporomandibular joint over a long enough period of time. You will get consistent diminishment of inflammation. And the final one is surgery, which I'm well established and well familiar with, both open joint surgery and arthroscopic surgery. And again, in my own evaluation, after 2,000 temporomandibular joint surgeries, half of them through an arthroscope and half of them open joint surgery, I can just summarize it. That is the reason I quit doing temporomandibular joint surgery, because the results were not adequate. We had some good results, and to this day, I have patients who are 20, 30 years out who come into my office where I operated on one side, which has no symptoms, but now the other side of their masticatory mechanism has developed symptoms of TMD, at which we put them into a device over the proper protocol, and their symptoms are relieved consistently over the long term. So those are the facts and the considerations as to why all of the symptomatic treatments for temporomandibular joint symptoms that have been going on for decades have not been effective, because they don't address the actual common denominator and cause within the temporomandibular joint. I hope I've made it very clear. I hope you think about this a little bit. That's my point. My point is not to convince you. My point is to stimulate you to think, and if you really want to be stimulated, look in the literature. Think for yourself. Look up and see. Read some articles. Think about the pathophysiology of chronic inflammation in this disease, TMD, and other diseases, and the fact that this joint is no different than any other joint in the body. It operates on the same principles as any other joint in the body. And if I made any discovery, that was the discovery that this joint operates on all the same principles that hips, knees, and elbows operate on, which is that principle of sympathetic nervous system stimulating muscle contraction under the influence of the temporomandibular joint in that area of the masticatory system. So for today, I'm looking forward to the next Tuesday when we're going to do this again. We'll have another episode of a selected topic. Hopefully will stimulate you to think, give you some more information, and hopefully get you interested in treating this problem and not being afraid to treat this problem. This problem is not hard to treat when you understand it. It truly is. It is an easy problem to treat. TMD is actually very easy to treat when you understand the proper, appropriate pathophysiology of the problem. With that being said, I look forward to next Tuesday. I look forward to the next time that you join me for an episode of TMD Demystified. I am Tony Urbanic.